right. Hello, everyone. I'm Juliette Knowles. I'm from Stanford University, and I'm going to be talking to you about building consensus to standardize LGS care. All right. So I'm going to argue today that we need a treatment guideline for Lennox-Gastaut syndrome that is updated and comprehensive, evidence-informed, but ultimately based on a broad consensus. And I will unpack each of those terms one by one. I will then tell you about ongoing efforts to build such a consensus-based guideline for North America. And I'll mention right now that there is also a wonderful effort going on by the ILAE, the International League Against Epilepsy, which is being led by Dr. Kere Valente, who happens to be in the audience today. I just met her. It was thrilling. To build a guideline based on international consensus. So there's a lot of exciting work going on in this space. And I won't say any more about that because I'm not involved in that effort personally. But first, let's go over the rationale for all of this. So why is a treatment guideline needed? Well, as you've heard a lot today, there are 8 FDA-approved medications for LGS listed here in the order in which they were approved: clonazepam, felbamate, lamotrigine, topiramate, rufinamide, let's start over. Clonazepam, felbamate, lamotrigine, topiramate, rufinamide, clobazam, cannabidiol, and fenfluramine. And you've heard, a lot about the evidence behind these already, so I won't repeat that. You've also heard that each of these can reduce seizures by about 30 to 40%, give or take some. For example, clobazam, seems to maybe have a little bit of extra efficacy in reducing drop seizures. There is also a collection of other anti-seizure medications that are not FDA approved for the indication of Lennox-Gastaut syndrome, but nevertheless are frequently used for this. And perhaps the most prominent one is valproic acid. Then there are the non-pharmacological treatments that we've been talking about all day: neuromodulation, VNS, DBS, RNS, palliative surgery, especially corpus callosotomy, resective surgery, and dietary therapies such as the ketogenic diet. So, as you've been hearing, what we do as neurologists and epileptologists when we're trying to help somebody with LGS is we take a good look at the person in front of us, and we listen to what they and their caregivers have to say. And we think about the etiology that originally led to the LGS. We think about the seizures that that person is dealing with, the type of seizures that they're dealing with at that point in time, and the other conditions that they might be experiencing, neuropsychiatric conditions, other systemic conditions. We consider the other treatments that they might be taking, and we think about drug-drug interactions, and we factor all of that together, and we come up with a personalized treatment plan that may involve pharmacologic and non-pharmacologic options. And despite our best efforts, 90% of people, or more than 90% of people with LGS, have refractory epilepsy. And one very plausible reason for this suboptimal outcome is variation or inconsistency of care. And we hear from patient advocacy groups like the LGS Foundation that there is an impression among caregivers and families of people with LGS that when they go from one center to another and one provider to another, that they get very different advice from different providers about the kinds of treatments that they should be using. And so in preparing for this talk, I turned to the literature thinking that I would find a lot of papers describing variation of care in LGS and perhaps a burgeoning QI effort to address that. And I found very little, just very little work being done. And I was surprised by that. So I turned to my colleagues to see if they knew of work, and everybody said that they really didn't know of any work being done. And so this seems to be a real gap in the field that we need to address. And if any of you experts, this is the meeting of the minds, if any of you experts in the audience know of such work, please send it my way. But in the meantime, I will show you this piece of data from the 2018 LGS Foundation Caregiver Survey, in which they collected data from 413 caregivers about their loved ones that had LGS. And they reported that their loved ones, 99.8% of them, of course, had received anti-seizure medications. Frequently, they had received rescue medications. About a third had received treatment with a neurostimulator, and a minority had undergone brain surgery or received dietary therapies. 75% reported that they had given somewhere between 3 and 10 different drugs to treat the LGS, hopefully not all at once. And those are the top 5 drugs that were given. So we don't have a lot of information from the literature, but taken together, the information we do have is suggestive of polypharmacy, variation of care, and underutilization of some potentially very helpful resources. So simply standardizing care seems like low-hanging fruit that could potentially substantially improve outcomes. But that's not a new idea. Standardizing treatment with consensus guidelines for LGS has been an idea that's been around for a while. So here are some examples of guidelines that have been put out for LGS care. In 2004 and 2018, the AAN and AES suggested lamotrigine and topiramate as first-line medications for LGS. And then in 2007 and 2017, European expert opinion was that valproate and lamotrigine, for example, were some of the top medications. Here is an example of a more recent guideline that you've seen a few times today already. And this was put together by my colleagues Deba Pam Samantha and Dr. Erin Warren, who are on the LGS SIG that you just heard about as part of the Pediatric Epilepsy Research Consortium. And what Dr. Samantha and Warren and the group of 12 experts from the SIG did was a narrative literature review followed by an iterative consensus project. And through that process, what they did is they ranked these commonly used medications for LGS into 4 tiers with some suggestions on personalization of the use of those medications. So in the first tier were valproate and clobazam. And then in the second tier were cannabidiol, rufinamide, topiramate, and lamotrigine. Third tier, fenfluramine, felbamate, and then you can see the medications in the 4th tier. For comparison, here is another guideline put out also through a process of narrative review followed by expert consensus by European colleagues, Stefan Ovan and Helen Cross, published around the same time. They recommended starting with valproic acid, followed by lamotrigine, then rufinamide, and then the next line therapies included clobazam, cannabidiol, topiramate, and fenfluramine. So, the 2 guidelines are not identical, but the same players seem to appear, and they're somewhat similar. So, pretty good in terms of comparativeness. So perhaps because of the sheer complexity of having to rank all of these options of ASMs on the backdrop of an already complicated disease, many of these types of treatment algorithms have sort of given, sort of a secondary look to the non-pharmacological therapies that we've been talking about. And yet, as you've heard this morning, Dr. Worrell gave a really beautiful overview of the evidence behind that's emerging for these non-pharmacological therapies. And I've put some of it up here, but I don't think I'll repeat it since she did such a great job. It seems that this evidence, despite the evidence for non-pharmacological treatments like dietary therapies, resective surgery, corpus callosotomy, and neuromodulation, despite that evidence, these therapies haven't quite made their way into our sort of standard thinking about how to take care of these patients. And people aren't yet comfortable with it. So I think we need to start being more proactive in integrating them into our treatment algorithms. So that is part of why I think an updated and comprehensive guideline is needed, and that's how we're thinking about it. Furthermore, I think we can do more to build on these really excellent efforts that I just talked about in the prior slides, the prior guidelines that have been developed. They were relied on, narrative reviews and limited expert consensus. I think that we can go further, integrating the evidence that's accumulated over decades on LGS and treatments for LGS with scoping reviews, for example, and by really sampling broad expert opinion through a process like a Delphi process. Now, you might be asking, why do we need expert consensus? Why not just rely on evidence? Isn't that the best thing? Well, we have a very limited evidence base for LGS. There are no monotherapy trials, so it's very difficult to evaluate individual therapies' efficacy. And head-to-head comparisons have not been carried out, although some in the field, like Drs. Anup Patel and Sandy Lamb, are working on this. Also, there's variation in trial design, so it's very hard to compare, the results of one trial to another in things like meta-analyses. The definition of LGS or, how drop seizures are defined in one trial compared to another varies. So meta-analyses have not been especially helpful for LGS. So hopefully, I've convinced you that we are ready for another more definitive version of a treatment guideline for LGS that is updated, comprehensive, evidence-informed, for example, with the scoping review and based on broad consensus, for example, with the Delphi process. And now I'm going to tell you about our plan to do this for North America. So this is work that is being done by the PERC LGS SIG. It's being led primarily by Dr. Anthony Fine, who's very sorry that he couldn't be here today to present this work himself, but I'm going to do my best as his helper on this project. And the work is being supported by the LGS Foundation. So the plan is to conduct a rigorous scoping review of the literature on treatments for LGS, to use that to inform a Delphi process in which we will systematically survey the opinions of experts from Canada and the United States who are clinicians that take care of people with Lennox-Gastaut syndrome, who are both adult providers and pediatric providers, and to use all of this information to then develop an integrated, comprehensive, and updated treatment guideline. And so this is work in progress, but I'll tell you where we are so far. We began the scoping review by working with the Mayo Clinic IT librarian, who helped us to develop a mesh search term encompassing pharmacologic, dietary, surgical, and neuromodulation treatments for LGS over the last approximately 40 years. That got us 936 abstracts, and we sorted through those using inclusion and exclusion criteria. We included abstracts for both children and adults, no age limit, because of course we want to get information about LGS treatments across the lifespan. Of course, people in the studies had to have an LGS diagnosis, and we wanted information on pharmacological, dietary, neuromodulation, and surgical treatments. There had to be outcomes related to seizures or comorbidities. And we included a variety of trial designs that are listed there, but we did not include things like scoping reviews, meta-analyses, systematic reviews, et cetera. So we wanted to be very rigorous about this. So for all of the abstract screening, we had 2 reviewers review each abstract. So actually it's more like 2,000 abstracts. And then if they disagreed on including or excluding, then the conflicts were reviewed, the conflicts were resolved by a 3rd reviewer. And we're very lucky that we have a large team of great people doing this, so the work is spread out. And all of the team members are listed there from the LGS SIG. And how many of you have used Covidence to do a project like this? It's a software tool for systematic and scoping reviews. It's kind of fun. I just put a snapshot of the dashboard there. I try to look at the bright side. It kind of gamifies it for you. It's like you have this many to go, and it uses an AI algorithm to feed you the most relevant abstracts first. So anyway, we narrowed it down to 414 full texts, and again went through 2 reviewers with conflict resolution. And then we got down to 195 publications that were deemed appropriate for inclusion in our scoping review. And those are now undergoing data extraction, and we're 50% of the way there. And data extraction is done by 2 separate reviewers, and if anything about the data that is extracted is different, then that goes through a process called consensus by a 3rd reviewer. So this is very a rigorous and thorough process. Of those articles, 134 are on pharmacological therapies, 41 are on neuromodulation, 12 are on surgery, and 8 are on dietary therapies. This is what the data extraction page looks like in Covidence. It's kind of like a very simple REDCap database page. It doesn't have branching logic. It's very simple. And one of the most challenging parts of this was to try to design a database or a data entry form that was specific enough to get all the data that we wanted from every paper, but broad enough that it wouldn't be too detailed and it would be applicable to all the different papers in our review. So we went through multiple iterations of this and beta tested it multiple times with our team members who were very patient and good-natured. And so these are the types of data fields that we wound up with. So as I mentioned, we're well on our way with this, and we have, for example, completed all of the VNS articles. And this is the kind of thing, the kind of information that you can wind up with the scoping review. It is qualitative. We decided that this was appropriate, for LGS, given sort of the limitations of, different, the different types of studies that you have for LGS. So VNS appears similarly effective in lowering seizures in LGS as other types of refractory epilepsy. There appears to be an additive benefit of VNS when combined with other interventions like DBS and corpus callosotomy. There is limited evidence for beneficial effects of VNS on comorbidities. And as we put this scoping review together, we will be rating the quality of evidence informing these assertions, which I think will be really important to sort of put these in context. We'll take the scoping review, we'll then use this to educate our experts as we conduct our North American Delphi process, and then we will develop a guideline that includes pharmacological and non-pharmacological treatments with recommendations across the lifespan. So hopefully this has gotten you all excited about developing the best possible evidence-based guideline that we can for North America and hopefully for the international community. But we need more than a treatment guideline to improve outcomes, as you've heard. Once we're done with this, we'll be into the implementation phase. So if you're excited about this, please, come talk to me. Come join the LGS, the PERC LGS SIG, where we have years of work to do after this and a lot of exciting work to do. So thank you so much, and look forward to talking to you after the session.
We are all over that group for this too. So, yeah, it looks like there's a question back there.
Julia, are you using steroids? Is that one of the treatments?
Can you hear him?
Yeah, the question was about steroids. That's a good question. I mean, we certainly didn't exclude it. So, there's nothing in the mesh term that would have excluded that. So if there are papers out there on steroids for LGS, they should have made their way into the review. Yeah. Yeah. I will say that there are a lot of the people that are on the team that's reviewing them are in the audience here, like Julianne, or, have you seen any steroid papers so far? Anyway, yeah.
And a lot of them are European, so we do see a lot of, I would say, things. I've never been accused of needing a microphone, but we don't see a lot regarding steroids, and a lot of them are international studies, and they are using different therapies. But it's very interesting you asked that question. But we have not seen a lot of steroids. Yeah, similarly, you don't, I mean, it's not like we're selecting for certain things, they're just coming through and we just don't see it. A lot of it is what Juliet's mentioning is combination therapy. Does CNS work, or sorry, does VNS work better with corpus callosotomy? Does this and then this? Which I think is very interesting because we don't have that kind of comparative data. And I think we're going to be coming up with a lot of that information, but it is interesting. We don't see those various therapies looked at.
Yeah, but I know, Zach, when we wrote our landscape paper, the first paper for the SIG that Deborah Pam mentioned in Annals of Clinical and Translational Neurology, we had a section on steroids, and there is a small literature on that. That's really intriguing. Yeah, so I think it would be a great topic to run by the Delphi expert committee.
Do we rule out cases?
Less than 10. Case series less than 10. Yeah.
I just thought of another quick question. As a parent, often it seems like there's an absence of information about expectations of when should we see, like, when should you give up hope on a particular treatment? Like in terms of what is the reasonable amount of time? What are the guidelines in terms of that we should see a change? And when to know of, like, okay, we need to move on, start weaning, or seek a different treatment.
Yeah, I mean, that's a great question. I mean, in standard clinical practice, like, we usually titrate up and then we give it, a few weeks to maybe a couple of months. And then, that's, like in my practice, if we haven't seen something by then, I usually move on. And usually if you haven't seen a meaningful change, then you should titrate off that medication. You shouldn't leave it on. But, of course, there's always nuances, and there's variation of practice. But that's a great, I mean, we should, one thing that was great about the Cross and Ovan, I showed the two treatment, the color-coded treatments side by side, the treatment guidelines. And one thing I really liked about the Cross and Ovan European guideline was they were very explicit about, if you're starting a new one of these medications, make sure you're titrating off one of the others, that if it didn't work. And I thought that was a really great element because there is such a risk of polypharmacy contributing to, sort of the comorbidities. And so I think that's a great suggestion that, we make sure we include that, in our guideline.
And particularly in the context where many of our kids are on like 6 anti-seizure meds. And, so I have an 18-year-old and, believe me, I've been weaning meds, it feels like his whole life. And having some guidelines in terms of, like, when you're trying a new med, I think empowering the parent or the caregiver of, basically pursuing an appointment sooner or, like, advocating to have that conversation, because it's so easy to end up on 5 or 6 AEDs, right? And then it gets really complicated in terms of weaning them off.